Hello, everyone. Thank you for joining. We will get started in just a few minutes. Hi, everyone. Thank you for joining. We'll give folks another minute or so before we get started. Hello, everyone, and welcome to our Plan Design and Comparison webinar. Thank you for joining us today. My name is Nicole Rapfogel. Beyond the Basics is a project of the Center on Budget and Policy Priorities. It's designed to provide training and resources to facilitate enrollment in the ACA health insurance marketplace and Medicaid. We are a nonprofit policy organization and are not a part of the U.S. Department of Health and Human Services. Beyond the Basics is aimed at healthcare assisters, advocates, state and local officials, and others who help people get and keep their coverage. This webinar is not intended for press purposes, and while we hope you will learn a lot, we are not able to offer continuing education credit for our webinars at this time. Today's webinar is the fifth in our fall webinar series. We will hold webinars on a variety of Marketplace and Medicaid topics each Tuesday at 2 p.m. Eastern until October 28th. We hope you can join us again next week at our webinar about the auto-renewal process on healthcare.gov. After the webinar, we'll circulate the slides, a video recording of this presentation, and other resources. We'll also post everything to the Beyond the Basics website. Automated captions have been enabled for this webinar. To view them, click the More option with 3 dots at the bottom of your screen and turn on closed captioning. All participants are muted and in listen-only mode. If you'd like to ask a question, click on the Q&A icon at the bottom of your webinar screen and type your question into the box. We'll be monitoring questions and we'll have a Q&A partway through the presentation and again at the end. We'll also try to answer as many questions as we can in the chat as we go along. We have a lot of content to cover and may not be able to answer every question asked, but we will have a record of all your questions and we'll use them as a guide for future resources and presentations. You can also email your questions during and after the webinar to beyondthebasics@cbpp.org. Today's webinar will be about plan design and plan comparison. We'll discuss elements of qualified health plans, an overview of cost-sharing charges, the meaning of metal levels and actuarial value, cost-sharing reductions for people with lower incomes, health savings accounts, plan comparison resources, and subpar plans. Today's presenter is Claire Heyison, Senior Policy Analyst at CBPP. We are also grateful to have 3 guest technical assistance providers to help us answer questions today: Caroline Gomez-Tom, Lynn Cowles, and Steve Goldman. One important thing to note: the premium tax credit enhancements currently in effect expire at the end of 2025. In this webinar, we assume these enhancements, including the availability of PTC to people with incomes greater than 400% of the federal poverty level, or FPL, are no longer available in 2026. This is subject to change pending congressional action. And now Claire will get us started.
Thanks, Nicole, and thank you everyone for joining us today for this webinar on plan design. Before we get started with an explanation of qualified health plans and some of the features that they have, we wanted to cover some changes coming to the ACA marketplace. As you may know, the Reconciliation Mega Bill, the 2025 Marketplace Integrity and Affordability Final Rule, and other administrative actions this year have made several changes related to plan design that will go into effect over the course of the next 3 years. These changes will impact coverage of gender-affirming care, the bronze to silver automatic re-enrollment crosswalk, catastrophic plans, and health savings accounts. We'll be sure to highlight all of those changes throughout the presentation. Now, let's start with some basic information about qualified health plans, or QHPs, which are the plans sold on the marketplace. Qualified plans, or QHPs, are insurance plans that must meet certain standards and include consumer protections outlined in the Affordable Care Act. These include having coverage for pre-existing conditions, covering the 10 essential health benefits, or EHB, limiting enrollee cost sharing, and not having any annual or lifetime limits on benefits. QHPs must also be certified by the Federal Health Insurance Marketplace or a state-based marketplace. These are the 10 EHBs that all QHPs must cover. They include preventive care, hospital care, prescription medications, maternity care, pediatric care, and more. As you may have heard, the final regulation issued this summer prohibits states from designating gender-affirming care as an essential health benefit beginning in plan year 2026. Now, plans can still choose to cover gender-affirming care, and states are still able to prohibit exclusions of gender-affirming care using other policy mechanisms, but they'll need to defray the cost of providing that care themselves. Bottom line, it's possible that fewer plans will cover gender-affirming care next year as a result of this change, but that doesn't necessarily mean that coverage is going away entirely. Another important element of all health plans, including QHPs, is the plan network. A plan's network is made up of all of the physicians, hospitals, and pharmacies that have contracted with the plan to provide services to plan enrollees. Providers the insurance company doesn't contract with are considered out-of-network. Some plans will cover services that the plan enrollee receives from out-of-network providers, but they'll usually have to pay more out-of-pocket than they would if they went to an in-network provider. And some plans won't cover any services received from an out-of-network provider, except in cases of a medical emergency. It's very important to know that every plan has its own network, and even plans offered by the same insurer can have different networks. It's important to check each plan's network when comparing options. Now, Checking plan networks with the insurer is a good practice. I would say that having the person that you're helping call their preferred healthcare providers to ask if they'll be in network with a particular insurer is a best practice, since healthcare providers tend to be the best source of information about whether they are participating in a particular insurance network. Also, keep in mind that providers can leave or change healthcare networks mid-year. So it's important to remind consumers to check in with their healthcare providers before their appointments to make sure that their insurance is still accepted. These are 4 basic types of health plan networks, and they're listed here with the least expensive but most restrictive network type on the left, and the most expensive but least restrictive plan network type on the right. This diagram highlights 2 features that distinguish between these types of health plans. The first is whether the plan requires people to get a referral from their primary care provider in order to see specialists. And the second is whether the plan will cover some out-of-network care or no out-of-network care. HMOs require a person to get a referral from their primary care provider before seeing a specialist and don't cover any out-of-network care. EPOs don't require a referral, but don't cover out-of-network care. POS plans require referrals and cover out-of-network care, and PPOs don't require referrals and cover out-of-network care. This diagram is just a different representation of the same information, also with the important reminder that all marketplace plans must hold enrollees harmless in case of a life-threatening out-of-network emergency room visit. Most health plans also include a formulary. A formulary is a list of medications an insurance plan will pay for. The formulary splits up covered medications into categories or tiers to indicate the level of coverage the plan provides, and the portion of the cost the enrollee will have to pay for various medications. The higher the tier of the medication, the more the enrollee will likely have to pay. Generic medications are usually in the lowest tier, which means the enrollee will pay the least for these medications. Medications not listed in the formulary are generally not covered by the plan, although exceptions may apply. So we've covered networks and formularies. Now let's talk about cost. There are 2 main categories to be aware of when it comes to plan cost. Premiums are the monthly cost a person pays for their health insurance plan. Premiums must be paid every month or the person's plan may be terminated. Whereas cost-sharing charges are the costs that a person pays as they use healthcare services that are covered by their insurance plan. All right. And you can find all of this information on the plan cards listed on healthcare.gov. You can view this information as part of the plan selection process in the application or through the healthcare.gov window shopping tool. At the top, there's basic plan information like the plan name and metal level and network type. In the middle, there's detailed information about cost sharing. And at the bottom, you can enter in a person's preferred healthcare provider or medications they know they'll need and see at a glance whether those things are covered by the plan. Now, a quick note on the prescription drug lookup part of the plan description summary. This will show you whether or not the prescription drug is covered. However, it won't tell you where on the formulary the prescription drug is and how much it will cost the enrollee. To view this information, you'll want to look at the plan's specific formulary. Next, let's take a deeper dive into cost sharing charges. We'll spend a lot of today's presentation focused on cost sharing, given how complex this topic is and how consequential it can be for enrollees. Let's start by talking about different types of cost sharing. Copayments are a dollar amount that an enrollee pays for healthcare services and prescriptions. An example would be $20 for a primary care visit. Coinsurance is a percentage that an enrollee pays for healthcare services and prescriptions. An example of coinsurance is 30% of the cost of a hospital visit. A deductible is the amount an enrollee must pay out of pocket for healthcare services before their insurance plan starts paying for the majority of the costs. However, some plans offer pre-deductible coverage, which we'll talk about shortly. The out-of-pocket maximum is the maximum amount that an enrollee would pay out of pocket in a year with a particular health plan for covered in-network services, typically. After the out-of-pocket maximum is reached, the plan pays 100% of covered healthcare costs. As I mentioned, some plans may cover certain services pre-deductible. So let's say a person has a plan with a $3,000 deductible and a $25 copay for primary care sick visits. If a plan covers primary care sick visits pre-deductible, then the person will only pay $25 for that service starting on day one. If the plan doesn't cover primary care sick visits pre-deductible, the enrollee will need to spend $3,000 out of their own pocket, and once they've reached that limit, they will pay the $25 copay. Additionally, keep in mind that some plans may have a separate deductible for prescription drugs and medical care. Finally, thanks to the ACA, preventive care services are required to be provided without any cost sharing. Some examples of preventive care are well woman visits, screenings for cancer, diabetes, or hypertension, immunizations, and FDA-approved contraceptives. The maximum out-of-pocket limit puts a cap on the amount an enrollee can pay in cost-sharing charges in a year, protecting people from very high out-of-pocket costs. It's set on a yearly basis and applies to in-network services generally not out-of-network care. An out-of-pocket limit is not the amount that an enrollee must spend each year. In fact, most people won't reach their out-of-pocket maximum. The limit is the maximum amount that an enrollee could spend in a year. Copays, coinsurance, and the amount an enrollee pays toward their deductible are all counted toward the out-of-pocket maximum, but premium payments are not. After an enrollee reaches the out-of-pocket limit, the insurance plan pays for 100% of in-network healthcare costs with no copays or no coinsurance. Some plans will have the maximum out-of-pocket limits allowed, while other plans will have lower out-of-pocket limits. And you'll see at the bottom of the slide the maximum out-of-pocket limit for 2026 coverage. Plans can, of course, choose to offer out-of-pocket maximums below these limits, but not above them. Let's talk about how this works. So this is Liana. For this example, we're going to assume that all of the care Liana receives is in-network, and we're going to assume that the healthcare incident we're going to talk about occurs at the start of the year before she's received any other healthcare. So Liana had a bad year and incurred $25,000 in medical expenses. She's responsible for paying the full amount of her medical expenses up to her annual deductible, which is $5,500. After she reaches the deductible, Liana pays copayments and coinsurance, and the insurer pays for the rest of the cost. That is until she hits her out-of-pocket limit at $8,900. After she reaches her out-of-pocket limit, Liana does not pay anything, and the insurer pays the full amount. As I mentioned, Okay, sorry. Up top here is an overview of Liana's cost-sharing requirements for the services that she needs after this $25,000 incident. Her plan generally covers 40% of her medical expenses after she reaches the deductible. So first, Liana receives an ambulance bill of $1,000. This is before she meets her deductible, so she is responsible for the full amount. Next, she receives a bill for hospital facility and hospital physician fees. And at this point, she hits her deductible, and so she pays 40% of her care, and the plan pays 60%. She continues to pay 40% until she reaches the out-of-pocket maximum. And after this point, all of her medical services, are covered by her insurer. Now, I mentioned earlier that we're assuming that Liana's care is provided entirely by in-network doctors. And this is important because she would likely end up paying much more if she went to an out-of-network hospital. In this example, we see that an enrollee has a plan that requires a $25 copay for an in-network primary care visit. And this service does not require the enrollee to meet their deductible first. They pay $25 per visit from day one of their coverage. For an out-of-network primary care visit, the enrollee would have to pay 50% of the allowable cost of the visit. The allowable cost is the maximum amount that a health insurer decides they will pay for an out-of-network visit. And oftentimes, doctors' offices and hospitals will charge more than that allowable amount, leaving the patient on the hook for any amounts above what their insurer will pay. Excuse me. The key takeaway here is that it's important to help someone choose a plan that has their doctors or health clinics in network. Otherwise, they could end up paying much more for their care. Next, we'll talk about actuarial value. This term refers to the generosity of a plan, or how much of the cost of healthcare the plan will pay for versus how much the enrollee will pay for. It's why marketplace plans have different metal levels. Actuarial value measures the percent of annual healthcare costs that a plan is expected to cover on average for in-network covered benefits for a typical population. A typical population includes people with no healthcare use, people with very expensive healthcare needs, and everything in between. So, marketplace plans are organized into 4 metal levels: bronze, silver, gold, and platinum, and each metal level is associated with a different actuarial value. The higher the AV, the less cost sharing the enrollee must pay. Now, remember that AV is calculated based on a typical population. It does not represent what the plan would pay for a particular individual enrolled in the plan. An enrollee's actual out-of-pocket costs depend on the medical services they use. Also, AV shouldn't be confused with coinsurance. If a plan has 70% AV, that doesn't mean that the enrollee will have to pay a 30% coinsurance charge for services. Actuarial value is not meant to represent the quality of the plan, the quality of the care provided under the plan, or the size of the plan's network. These are the metal tiers for qualified health plans, and each metal level corresponds to an actuarial value. For example, silver plans have 70% actuarial value. Plans with higher actuarial value cover a greater percent of the cost of health services. However, they also tend to have higher premiums. These are 4 examples of plans at different metal levels: bronze, silver, gold, and platinum. This example is looking at, what these plans cost with no premium tax credits, so no financial help. As you can see, the bronze plan has the lowest premium, but also the highest deductible, out-of-pocket maximum, copays, and coinsurance, whereas the Platinum plan has the highest premium but the lowest cost-sharing amounts. You may have noticed on one of the previous slides that in addition to the 4 metal levels of QHPs, there are also catastrophic plans. Catastrophic plans are sold on and off the marketplace and typically have lower premiums and higher out-of-pocket costs, including very high deductibles compared to bronze plans, even. These plans cover the essential health benefits but offer few services pre-deductible other than preventive care. Importantly, people who enroll in a catastrophic plan do not qualify for premium tax credits. Historically, these plans were available to people under age 30 and people for whom premiums for a marketplace plan exceeded a certain percentage of their income. People could also request a hardship exemption to enroll in a catastrophic plan. Recently, HHS announced that more people will qualify for a hardship exemption to enroll in a catastrophic plan. People with income below 100% of the poverty level or above 250% of the poverty level who expect to be newly eligible for the premium tax credit or cost-sharing reductions can now qualify. Before someone requests an exemption to enroll in a catastrophic plan, they should receive a full eligibility determination for the premium tax credit and cost-sharing reductions. Although catastrophic plans may have low premiums, people may be eligible for financial help that makes enrolling in a plan of a different metal level more affordable. I think we're doing good on time, so I'm going to pause now to see if we can take any questions from the chat.
Thank you, Claire. That was really great. And yeah, we can do a couple of questions. So the first one is, could you explain integrated versus embedded deductibles?
Okay, so this question is related to health plans that cover more than one household member, first of all. If a plan has an integrated deductible, it means there's only one deductible for the whole household. And once the household meets that deductible, any post-deductible cost-sharing arrangements will kick in. An embedded deductible means that the plan has both individual and family deductibles. So for example, if a plan has a $1,000 individual deductible and a $2,000 family deductible. Under this scenario, if one person in the household spends $1,000 on out-of-pocket medical care, they will meet their deductible and any additional medical expenses will be subject to cost sharing like copays or coinsurance. But if another member of their household gets medical care, they'll still be subject to their deductible until either that person meets their individual deductible or both people meet the family deductible.
That's really helpful. Thanks, Claire. All right, I think we have time for one more question and then we'll revisit the rest at the end. How do I know if a plan is a catastrophic plan?
Good question. So first of all, not all markets have catastrophic plans available. Some states have restrictions on the sale of catastrophic plans, and not everyone qualifies for a catastrophic plan. So you won't necessarily be seeing catastrophic plans when you go in and look at available options. But when a person fills out a marketplace application or goes to the plan shopping tool, they will see catastrophic plans listed as options if they qualify for them and if they're available. So typically that would be if they're under age 30. The word catastrophic will be listed on the plan card on healthcare.gov in the same place that the metal level will usually be listed.
Thank you, Claire. All right, we will hold the rest until the end, and thanks so much. Carry on.
Thanks, Nicole. All right. So, as I mentioned earlier, there is financial help available for people at the lower end of the marketplace income scale that reduces the cost of deductibles, out-of-pocket limits, copays, and coinsurance. And in fact, about half of all marketplace enrollees are eligible for this assistance. It's called cost sharing reductions. In order to receive cost sharing reductions or CSRs, a person has to have income at or below 250% of the federal poverty level. So that's around $40,000 a year for a household of one, or $80,000 a year for a household of four. And you can click the yearly guidelines and thresholds link at the top of the slide, or I think someone might put it in the chat, to see the federal poverty level thresholds by different household sizes. So the lower a person's income, the more help they receive. And they also have to enroll in a silver plan in order to receive CSRs. On healthcare.gov, CSR plans are marked with an orange extra savings tag. This is an example of how cost sharing reduction plans work. So take a look at the plan ID that's highlighted in yellow, and you'll notice it's the same plan ID for all four of these examples, but you'll see that the premium and cost sharing amounts are different. That's because these amounts change based on a person's income. So as income decreases, the premium tax credit increases, and so that's why we see the premiums decreasing as well. But you'll also see that deductibles, out-of-pocket maximums, and other cost-sharing amounts decrease too. And that is because of cost-sharing reductions. Healthcare.gov automatically displays the silver plan variations or the CSR plan variations that correspond to the individual's income level. So in other words, the silver plans that a person sees will have the cost-sharing reductions built in if they're eligible for them. If someone has income above 250% of the federal poverty level, when they log into their account and look at this plan, they are seeing the standard silver version, which is in yellow here. The standard silver version of this plan has a deductible of $6,300 and an out-of-pocket maximum of $8,000. If someone has income between 200 and 250% of the federal poverty level, they will see the 73% AV version of the plan with cost sharing reductions applied. And you'll see that you'll be starting with this plan. You'll see the extra savings logo at the top in orange. The 73% AV plan variant in green has a deductible of $4,950 and an out-of-pocket maximum of $6,200. Moving lower on the income scale, someone with income between 150 and 200% of the federal poverty level will see the 87% actuarial plan variant, which has a $0 deductible and around a $3,000 out-of-pocket maximum. And finally, a person with income below 150% of the federal poverty level will see the 94% AV plan variant, in purple here, which has a $0 deductible and around a $1,000 out-of-pocket maximum. Bottom line, CSRs can significantly lower the cost of getting healthcare for people with lower incomes. In previous years, healthcare.gov implemented something called the bronze to silver crosswalk to move people who are eligible for cost sharing reductions but enrolled in a bronze plan into a silver plan with cost sharing reductions if the person didn't actively select a plan during open enrollment. This policy will not be in effect for the 2026 year in states that use healthcare.gov. State-based marketplaces can apply to HHS for an exemption from this policy. And the policy is banning or getting rid of the bronze to silver crosswalk is scheduled to sunset at the end of 2026. So let's get into an example of how a cost sharing reduction plan would work in the case of someone with high medical expenses. And it works essentially the same as our earlier cost sharing example. You'll just see that the amounts are lower. So this is Sam. And in 2025, Sam also has $25,000 in medical expenses. But unlike Liana, whose example we saw earlier, Sam has a silver plan and qualifies for cost sharing reductions. Sam's plan has an annual deductible of $850 and an annual out-of-pocket limit of $2,500. So Sam gets this huge medical bill. He's responsible for paying the full amount up to his deductible of $850. After that, he's responsible for co-payments and co-insurance, and the insurer pays for the rest of the cost of the services. So he pays an additional $1,650, and at that point, he meets his annual out-of-pocket limit. After that, Sam doesn't pay anything, and the insurer pays the full amount. So this means that in the end, Sam only ends up paying 10% of his total medical bill. As is the case with standard silver plans, there can be significant differences between CSR plans. They may have differences in benefits, visit limits, provider networks, and drug formularies. One insurer can offer multiple different silver plan options, each with its own set of cost sharing reduction variations that can differ substantially in terms of deductibles and copays. So both of the examples here are CSR plans, but you can see that Plan A has lower premiums, but higher deductibles and out-of-pocket maximums compared to Plan B. In addition, Plan A doesn't cover this person's medications. Well, it covers their person's medications, but it doesn't cover their healthcare providers. In this kind of situation, the person would need to choose whether they want to pay a lower premium and potentially face higher out-of-pocket costs and switch healthcare providers, or whether they're able to pay a higher premium in exchange for lower out-of-pocket costs and being able to keep their healthcare provider. Oops, sorry, I didn't realize that all of these animations were here. Okay. Special cost sharing assistance is available to members of federally recognized Native American tribes and Alaska Native Claims Settlement Act Corporation shareholders, which I'll abbreviate to AIAN. They can enroll in or change marketplace plans each month without needing to qualify for a special enrollment period. For AIAN people with income between 100 and 300% of the federal poverty level who qualify for the premium tax credit, plans with zero cost sharing are available. Enrollees pay no deductibles, co-payments, or other cost sharing when using in-network covered essential health benefits, and some out-of-network care is also available with zero cost sharing. For AIAN people with incomes below 100% FPL or above 300% FPL, there is a limited cost sharing plan available. And with this type of plan, the enrollee would pay no cost sharing charges to receive services from an Indian health service provider or from another provider if they get a referral. Another feature of or potential plan feature are health savings accounts or HSAs. So as the name suggests, a health savings account is a savings account that's paired with a health plan. HSAs are typically paired with plans, with higher deductibles and minimal pre-deductible coverage. This means that people who enroll in plans with HSAs are often responsible for most or all of their healthcare costs before they reach their deductible. The draw of plans with HSAs is that the accounts are tax advantaged. You aren't taxed when you add money to your HSA, and you don't have to pay tax when you withdraw money from your HSA, as long as the money is used to pay for qualified medical expenses. You can invest the money in your HSA, and your investment earnings are not taxed. And any money in the HSA that you don't use can roll over year. important to note, though, that some HSAs charge fees for opening or closing the account or monthly maintenance, so you will want to pay attention to that. Often plans with an HSA will include the abbreviation HSA or HDHP in the plan name, but if you want to be sure, you should check the plan details, as you can see here on the right, and that will say whether the plan is HSA eligible. On healthcare.gov, you can also filter specifically for HSA eligible plans. Previously, only high deductible health plans, meaning those with a deductible that was above a certain amount that applied to virtually all services except preventive care, could be paired with an HSA. But beginning in plan year 2026, all bronze and catastrophic marketplace plans can be paired with an HSA. This means we will very likely see plans that offer both HSAs and pre-deductible coverage. Now, this change doesn't mean that all bronze and catastrophic plans will offer an HSA. Insurers may choose to offer some bronze and catastrophic plans with HSAs and some plans without them. So how do you know if a plan with an HSA is right for you or the person you're helping? First, check and see if you're likely to be eligible for cost-sharing reductions. If so, it may not be worth giving up the cost-sharing reductions, which can significantly lower out-of-pocket healthcare costs, in order to enroll in a bronze or catastrophic plan with an HSA that isn't CSR eligible. Next, as with any other health plan, you'd want to consider your expected medical needs for the year and see how those match up with the coverage that's offered. In particular, now that HSAs can be paired with a plan with pre-deductible coverage, check to see whether any of the anticipated services or medications needed are exempt from the deductible. Otherwise, you'll be on the hook for 100% of the cost until you meet the deductible. Next, consider how much money you can reasonably afford to put into the HSA. Plans with HSAs probably aren't as valuable for people who can't afford to put as much into savings. Finally, consider whether the amount that you can afford to put into the HSA is enough to pay for your expected medical needs for the year. And consider also what might happen if you experience an unexpected high-cost medical event. Next, let's go over some resources that can help with plan comparison. So first, there's the plan filter tool, which can be used to set specific parameters when looking at plans. If you're helping someone apply for coverage, it can be helpful to start here to get a sense of how many plans are available in their area, what metal levels they fall under, and which insurance companies offer plans. You can then filter plans by how much someone is able to pay in monthly premiums, whether the plan covers particular prescription drugs or medical providers, plan metal level, and other features. For the past few years, insurers have been required to offer plans with standardized cost-sharing amounts. These are marked as easy pricing plans. Because cost-sharing is the same across all standardized plans, consumers can focus on other plan features, like in-network providers, when comparing plans. Health plans have so many different confusing components, and the idea behind easy pricing plans is that they take cost-sharing out of the equation. For this reason, it can be helpful to start the plan comparison process with easy pricing plans. And these are the easy pricing plan parameters for plan year 2026. So for example, all standardized gold plans will have a $2,000 deductible, an $8,200 out-of-pocket maximum, and a $30 copay for primary care visits. Healthcare.gov also offers this estimated total yearly cost feature. And the best way to think about this feature is not as a crystal ball, but as a simpler way to compare plan costs. Instead of looking separately at a plan's premium and cost sharing, the total yearly cost estimate gives one number that combines both, based on how much healthcare a person expects they'll need over the year. Keep in mind that this number assumes that the enrollee will only use in-network care, doesn't account for unexpected healthcare issues that arise, and obviously doesn't take into account people's specific healthcare needs or prescription drugs. Another very important plan resource is the Summary of Benefits and Coverage, and you can find this document by clicking Go to Plan Details on the healthcare.gov plan description. Then click on Plan Documents and Summary of Benefits and Coverage. The Summary of Benefits and Coverage provides a detailed look at what's covered by the plan, including cost-sharing amounts for in-network versus out-of-network care, as well as exceptions and limitations on coverage. I'd advise taking a look at this document later in the plan selection process, once you've found a plan or two that seem promising. Definitely too much information to start with. You'll definitely want to see if pre-deductible coverage is available for any healthcare services that you or the person you're helping might need routinely. And you'll also want to take a look at any exceptions to coverage to minimize unwanted surprises when people try to use their healthcare. For example, it may look like out-of-network urgent care is covered with a $30 copayment under this plan, but if you read the fine print, you'll see that this only applies if in-network providers are temporarily available or inaccessible. So some other things to watch out for. Some health plans now have tiered provider networks, meaning that there might be different coverage or copays for different groups of in-network providers. You'll see here that if someone sees a healthcare provider that is in the select PCP group, there will be no charge. But if they see an in-network provider who's not part of the select PCP group, they have an $105 copay. This is something that wouldn't necessarily show up in the plan description summary. Also, check to see if a referral is required for healthcare providers that you or the person you're helping expects to see. Some people are fine with the referral process, whereas for others, it could be a deal breaker. Either way, it's good to know what to expect and if you need referrals before you enroll in a plan. And last on our list of resources is our Marketplace Plan Comparison Worksheet. This worksheet allows you to compare up to 4 plans side by side. You can fill it out on your computer and then email it to your client, and it's available in multiple languages. Oops. To finish off, I want to spend a little more time than we've spent in previous years talking about subpar plans. These are plans available in the
Sorry, everyone. It seems like we're having a bit of technical difficulty. That Claire's audio just cut out. If you can bear with us just a second, we're working on it. All right, Claire, it looks like you are on Jenny's audio. Is that correct?
Yes.
All right.
Sorry, everyone, experiencing some technical issues today. But anyway, I know that I cut out for a second, but essentially we're spending a little bit more time than usual on subpar plans. These are plans that are available in the individual market that don't comply with the ACA's consumer protection standards. And I was saying more people may be considering these plans this year if the enhanced premium tax credits expire and the cost of ACA compliant coverage goes up. And so whether or not you are helping someone enroll in these type of plans, it's good to be aware that they are out there. Nicole, could you go to the next slide for me, please. Thank you. Okay. So as I said, subpar plans are those that don't meet standards outlined in the ACA for plans sold to individuals, and they're not certified by the federal health insurance market or state-based marketplaces. And there are some examples of these type of plans on the left. These plans don't have to include consumer protections, so they may charge higher premiums based on a person's gender or pre-existing conditions. They can deny coverage based on pre-existing conditions. They can impose annual or lifetime coverage limits, deny claims related to health services that relate to pre-existing conditions. They don't have to cover essential health benefits, and they can pay out limited amounts for health care. They expose people to high costs, and they are often not that cheap. Next slide.
I gave permissions back to you on slides. You should be good to go, Claire.
Thank you. Okay, so there are a few different things that you can do to help people navigate around subpar plans. Promote open enrollment and healthcare.gov or your state-based marketplace. Understand and inform people about enrolling in these type of plans. In particular, help them see past the low premiums that these plans might offer and understand the high costs that they may face down the road. Promote special enrollment periods for people who face coverage gaps, and track and report what's happening on the ground, including misleading or fraudulent marketing tactics, people receiving inaccurate information. You can track the experiences of consumers who enroll in these plans, inform insurance regulators in your state about potential fraud and misinformation, and inform individuals about their right to complain about wrongdoing. If your client is interested in exploring plans outside of the marketplace, these are some tips you can share to help them avoid scams and misleading sales pitches. I'm not going to go through all of these now, but felt it might be helpful to have this as a resource. And here is a brief checklist for people to ask before purchasing a health plan outside of the marketplace, particularly if they're shopping on their own. And these are also great questions for people to ask about purchasing a health plan in general. If enhancements to the premium tax credit expire at the end of this year, people are going to be facing some harsh trade-offs. This chart aims to serve as a quick reference when thinking about the value of a silver QHP, a bronze QHP, a catastrophic plan, a subpar plan, or no coverage. A few things to note here. The premium cost for the catastrophic plan I've listed as a question mark. This is because of the new change that allows more people to get a hardship exemption. It's possible that this will increase premiums for catastrophic plans. Also, because people can't use premium tax credits for catastrophic plans, their costs may be higher than enrolling in a bronze plan, depending on the amount of premium tax credit they're eligible for. For subpar plans, there are a lot of question marks. Deductibles and out-of-pocket costs vary across these plans, and some of them don't have out-of-pocket maximums at all. Coverage also varies widely among these plans. Finally, we know that with premiums going up and with deductibles being as high as they are, some people are thinking about whether it makes sense to have health insurance at all. There's no one right answer to that question, but keep in mind that with an ACA marketplace plan, even a bronze or catastrophic plan, you at least get free preventive care, coverage of essential health benefits, and a limit on how much you'll need to spend out of pocket on covered medical services in case of an emergency. For those who decide not to enroll in coverage or who aren't eligible for coverage or premium tax credits next year, you'll want to be sure to have resources available, like local community health centers or sliding scale clinics where they can get coverage, or sorry, where they can get care. So here's an example just looking at marketplace plans now. This is a person with income at 288% of the federal poverty level. She only qualifies for a PTC of $25 a month, so she's paying close to full price for her coverage. If we look at her options, the catastrophic plan has a premium that's similar to the bronze option, but it offers much less generous coverage. So if Angie can afford to pay around $270 a month in premiums, and that is a big if, she is probably better off going with the bronze option. If she can pay more for better coverage, then it's possible that she could upgrade to the silver option, which again has higher premiums but more robust coverage. And with that, I guess we'll move to the next phase of our Q&A.
Thank you, Claire. All right, we can jump right in. The first question is, why are there no platinum plans in some states?
Right. So health insurers are not required to offer platinum plans. In fact, if an insurer wants to sell plans on the ACA marketplace, they're only required to offer at least one silver and one gold plan, though most will offer bronze plans as well. In a lot of states, there just isn't much demand for platinum plans since they're expensive, and people with lower incomes qualify for CSRs, which, depending on the person's income level, can provide platinum-like coverage at silver level prices.
Thank you, Claire. All right, the next question. What happens if someone enrolls in a CSR plan, but at the end of the year, they earn too much to qualify for CSRs? Do they need to repay CSRs like they do with premium tax credits?
No, people do not need to repay CSRs if their actual annual income is higher than they projected. But similarly, people don't receive CSRs back if they underestimate their annual income. This is one of the reasons why it's important for people to update their marketplace applications if they experience a change in income or household size mid-year.
Thank you. All right. Are CSRs affected by the premium tax credit enhancement debate or any of the marketplace changes for plan year 2026?
This is a great question. As of now, the answer is no. So the enhanced premium tax credit debate is really just referring to the amount of premium tax credit that people receives. It will not affect the amount of cost sharing reductions that people are eligible for. And although there was some discussion earlier this year of changing how cost sharing reductions would be funded, as of now, we're not we're not anticipating any changes to that either.
Thank you. All right, so some state-based marketplaces are already allowing window shopping for open enrollment 2026. How are they basing the savings if we're not sure if PTC enhancements will be extended?
Great question. So not just for SBMs, for all marketplaces, insurers are assuming that the enhancements will go away at the end of the year. So for SBMs that are already allowing window shopping for open enrollment for 2026, the rates that you're seeing are based on the assumption that the enhancements will go away.
Thank you. All right, I think we have time for one more before we close out. So, will catastrophic plans cover 3 primary care visits per year in plan year 2026?
Yes, so catastrophic plans, like all other qualified health plans, are required to cover preventive care with no cost sharing. And catastrophic plans also are required to cover 3 primary care visits per year, but they typically don't cover any other services pre-deductible.
All right, thank you, Claire. This whole presentation has been incredibly helpful. So As a reminder, we will be distributing the materials from today's session via email, and we will post everything to the Beyond the Basics website at healthreformbeyondthebasics.org. You can review the resources listed on this slide for more information. Our annual fall webinar series will continue next Tuesday, October 14th, with a webinar on the auto renewal process on healthcare.gov. Subscribe to our email list to get the registration links. The link to subscribe is on the slide, and we will share it with other resources after the webinar. If you have any questions or need assistance, please email our Beyond the Basics contact email at beyondthebasics@cbpp.org. And with that, we will bring this webinar to a close. Thank you again for joining us today, and we hope to see you next week.